Okay, so today I lied a little bit. I told you guys we're doing ectopic pregnancy, right? But in truth, what we're doing today is that we're actually going to look at what a normal pregnancy looks like. The reason being, if you don't know what's normal, you don't know what's abnormal. Now, if any of you have worked with ultrasounds and pediatrics and obs and gynae before, that's great. You would have some experience. But for the majority of us, the majority of us, we've never had a chance to actually do pregnancy ultrasound. So let's say we've got to know what's normal before we know what's abnormal. Right? So that's kind of what we're going to concentrate on today. Okay. So this is kind of ectopic pregnancy part 1. And then next week will be ectopic pregnancy part 2. Okay. It should be everybody, hopefully. All right. So the first thing, but we are going to talk about ectopic pregnancies. All right. So the first thing that we have 2 types of ectopic pregnancies. So do you understand what an ectopic pregnancy means? That's the first thing. Any idea? No, I don't want to put anybody on the spot. You can just answer. Very good. All right. So that's it. That's the basic definition. It can occur in a lot of places, but that's basically the problem. So with anything, if it's not in its right place, it's going to cause problems. All right. So that's basically the issue. Now, what happens is with all ectopic pregnancies, a pregnancy can grow up to a particular size before it causes problems. And depending on where it is, it can grow very large before it causes problems, or it may not grow that large before it causes problems. And we'll talk about that now. And then you get 2 types. You get non-ruptured. In other words, those that are causing pain, but they haven't yet burst open. All right. And then you get ruptured, which means those that have burst open for whatever reason, wherever they may be. All right. So generally what you get, now, I mean, there's a lot of rare variants and things like that, but just talking about the common ones, you generally have a preg test that's positive. So that's why it's very important. Any female patient who comes of childbearing age, doesn't matter how old she may be, 13 years old, 14 years old, 48, 49, 50, these are all potentially childbearing ages. Do a pregnancy test, regardless of what's going on. Right? And that's the standard procedure here. And generally, they'll have low abdominal pain. Sometimes they can have PV bleeding, but that's about it. They don't really have much else. So you have this lady who's got a low abdominal pain, she's preg test positive, but there's not much else. The reason being, it's just because of the swelling associated with where the pregnancy is. So it's either pushing against a tube, pushing against an ovary, pushing against a viscera within the abdomen, expanding the wall of the uterus, whatever it may be. So this is what's causing a pain, right? And that's a whole discussion on its own. And then rupture, generally, when we are talking about rupture, it means now it's burst through its containment. So wherever it may be sitting, it's burst through, it started to. Okay. And the reason why it bleeds, pregnancy is a very vascular state to be. Okay. There's a lot of blood that needs to be supplied for a baby to grow. So generally, whatever surrounding the gestational sac is quite vascular. So you'll get a patient with pregnancy test that's positive. They'll have low abdominal pain, but they can be peritonitic. And the reason why they are peritonitic is because there's free fluid, there's blood in that abdomen. Okay. They don't generally have much PV bleeding, right? Contrary to popular belief. I know a lot of students who come before, they've always given that there's PV bleeding. PV bleeding may be there, but it's not the first thing that you look for. Okay. And then the patient is pale because they're not bleeding from veins, they're bleeding from arteries. Okay, generally, they are bleeding from veins as well, but they're bleeding from arteries. Now, if any of you have ever seen an artery bleed, even a tiny artery can lose a significant amount of blood in a very short period of time. So you do have to be careful about it. All right. So, and what I'm talking about now, we're going to revise next week as well. But I just wanted you guys just to have a look. So these are the types of ectopic pregnancies. So we start from the outside, or let's say the closest, you can have a cervical pregnancy. All right. These generally don't last very long. All right, they tend to even self-abort and things like that, but they can be lodged in the cervix and grow to quite a reasonable size. But because of the size of the cervix, it's unlikely that they'll go to a very large size before they rupture. Do you expect PV bleeding with this one? Yes. Is it a common variant? No. Okay, then you go to intramural. Let me just get this, sorry. All right, so intramural, all right, within the wall of the uterus, all right. So when a patient is pregnant, the uterine wall starts getting quite large. So most of these patients generally will come as a non-ruptured patient. All right, they may rupture. There's no doubt they may. It just depends how close to the center or the edge of the wall it may be. And then they may also present with PV bleeding, but not that much, surprisingly. All right. And then they generally will be peritonitic if they rupture. They bleed quite excessively if they rupture, but it's also not a common variant. Okay. Then you get interstitial corneal, in other words, in the horn of the uterus. Those ones there can occur relatively regularly. They can, if they are picked up in the early stages, they don't rupture because they do tend to cause pain quite early. And if they do rupture, they bleed quite a bit. And then you get the ones that are in the fallopian tubes. All right. You get isthmic, ampullary, infundibular. All right. All of these are the most common. All right. Generally, when you are going to see an ectopic pregnancy in practice, in an emergency department I'm talking about, this is generally where you'll see them. The reason why I mention that is most of the non-urgent, non-ruptured ones don't come to emergency departments. They are ladies who are pregnant, they are found to be pregnant, but the only thing that they've got is low abdominal pain. Their BPs are fine, their heart rates are fine, everything is fine. So they tend to get directed towards an outpatients department. And then with an elective ultrasound or beta HCG levels or whatever you want to use, then they discover that this is an ectopic pregnancy. And then they advise them on medical treatment. Sometimes surgical, but majority of the time it's medical treatment. Okay, so the ones we see are more commonly around here. And the only one that's missing over here is intra-abdominal, but we'll get, oh no, it is here, sorry. So what happens is your fallopian tube is not a thick structure. It's actually a very thin structure. If you've seen one in reality, it's actually literally like a straw. It's like just one of those big straws you get with a thick milkshake. That's what it kind of looks like, all right? So the wall is not very thick. So what happens is that these tend to rupture quite early. And when they do rupture, they tend to bleed quite a bit. Right, and there's not much PV bleeding because it's quite isolated from the cervix and the vagina. Okay, so these are the ones that we most commonly see. Are you always going to see them where they are? No, not necessarily. In fact, those are not the signs that we look for. And we're not going to concentrate on that this week. We're going to concentrate on that next week. But just a brief overview, what we're looking for is free fluid in the abdomen. Basically, that's what we're looking for. And next week, we're going to look at what you actually see, all right? And then you get ovarian as well. Ovarians are also relatively common, can rupture, can bleed quite a bit, and can often be mistaken for ovarian torsion as well. The main differentiating factor is your pregnancy test, right? So if you haven't done a pregnancy test, you won't know which it is. Even on ultrasound, it can be difficult. And then you get abdominal. So abdominal ones can actually grow to quite a significant size before they cause any problems, because it depends where it lands. Now, this is a whole, if you'd study to become a gynecologist obstetrician, they will spend a few weeks talking to you about abdominal ectopics, because it's something that you need to do, all right? It's something that you need to do. There are some others, the one that's called heterotopic, but we're not going to talk about that now. We'll cover it next week. So this is not an exhaustive list, but it gives you the most common ones that you'll see, all right? So like I said, today, what we are going to look at is a normal pregnancy. Now, fair warning, the guy who does the videos, wonderful. The amount of knowledge, exceptional. He's a bit of a nerd. So he doesn't have much enthusiasm in his voice, all right? But if you pay attention to what he says, you'll actually learn quite a bit. And you're not going to learn everything. It's going to take us about 15 minutes to go through the 2 videos. And that's where we're going to stop for today, all right? And then next week, we've got another 15 minutes of videos to actually cover the whole ectopic pregnancy thing. But like I say, we first need to know about normal. So we're going to cover quite a bit. And it's something that you can use later on as well when you are doing obstetric training and to how you actually look at a pregnancy. Why it's also good for us in an emergency department, sometimes you do get these cases, or uterine rupture, what you call it, pregnancy trauma, things like that. So you need to know how to assess a baby that's larger. You don't only look for ectopic, if I can put it that way. So we're going to get onto that now. I'm going to keep quiet. But fair warning, if you haven't had your coffee, you may fall asleep, but it's still well worth it to see. Okay. All right. Let's go to it.
Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this module entitled Emergency OBGYN Ultrasound Part 1, we're going to focus entirely on the ultrasound findings of intrauterine pregnancy. Now, patients with early pregnancy and vaginal bleeding with or without abdominal pain are frequently seen in the emergency department. Luckily for us, emergency OBGYN ultrasound has evolved to be one of the most helpful applications of sonography in a busy emergency medicine practice. So this module will focus primarily on the detection of intrauterine pregnancy, and will examine the ultrasound findings that define a normal pregnancy for an emergency physician sonographer. Before launching into the sonographic findings of a normal intrauterine pregnancy, let's take a moment to quickly review the OBGYN anatomy important for this application. We see the uterus to the left and adnexa to the right. Notice the areas of the uterus. We see the lower cervix, the intermediate body, and the fundal region towards the top of the uterus. Now, the fundal region is where we define an intrauterine pregnancy to be located. We see the area where the fallopian tube enters into the uterus, which is the interstitial region in a normal uterus, and the corneal region in a bicornate uterus. And this is where some variants of ectopics can implant. Notice the areas of the fallopian tube to the right, which we'll concentrate more on with regard to ectopic pregnancy. And we see the broad ligament there encasing the fallopian tube and the ovary as seen to the right. When taking care of a patient who has vaginal bleeding in pregnancy, there's four main classifications of diagnoses. The first is a threatened abortion, which is defined as the presence of an intrauterine pregnancy with bleeding. The second main classification encompasses several different terms. The terms that are commonly used are incomplete abortion, missed abortion, blighted ovum, and fetal demise. Basically, all of these mean the presence of fetal membranes or parts without expected fetal growth or cardiac activity. The third main classification is a completed abortion, in which there's no further presence of fetal membranes or parts, and on examination, usually the cervical os will be closed. And the fourth main classification is the most dangerous, is ectopic pregnancy. Here's a table showing the structures in pregnancy and about the time that they're seen on transvaginal versus transabdominal sonography. As we look in the embryonic structure column to the left, we see the first structure that appears as a gestational sac seen on transvaginal sonography at about 4.5 to 5 weeks and about a week later on transabdominal sonography. The yolk sac is seen at about 5 to 5.5 weeks on transvaginal sonography and a week later on transabdominal sonography. And I have this circled in red as this is really the way we diagnose an intrauterine pregnancy. Now note the fetal pole is seen at about 5.5 to 6 weeks on transvaginal sonography and a week later on transabdominal sonography. The last main finding, which is a fetal heartbeat, is seen at about 6 weeks on transvaginal sonography and about at 7 weeks on transabdominal sonography. Another important concept for OBGYN sonography is the correlation of the serum beta-HCG to the findings of a normal pregnancy. As we see here for transvaginal sonography, the discriminatory zone at which we will see findings of an intrauterine pregnancy are about 1,500 to 2,000 milli-international units. For transabdominal sonography, the discriminatory zone is about 6,500 milli-international units. Now, this rule does not apply to ectopic pregnancies, which secrete beta-HCG at atypical levels and are commonly seen with betas all over the map. They can be seen with betas lower than 1,000 and as high as 30,000. The first finding that will occur during an intrauterine pregnancy is going to be a gestational sac, and as we see here in the ultrasound picture to the right, it's a small round circle that's dark or hypoechoic in relation to the rest of the uterus. We actually see a gestational sac below that came out of a patient. Notice that it has a translucent membrane type appearance. Unfortunately, gestational sac is not diagnostic of an intrauterine pregnancy, as a pseudogestational sac of ectopic pregnancy can be seen from hormonal stimulation. So as a general rule of emergency ultrasound is that visualization of a gestational sac is not adequate to call an intrauterine pregnancy. Here's two video clips showing the gestational sac, long axis to the left and short axis to the right. We see here a very small diameter gestational sac in both of these orientations. Unfortunately, this can be seen with a pseudogestational sac of ectopic pregnancy. So a small gestational sac like this is in no way diagnostic of an intrauterine pregnancy for the emergency physician sonographer. Remember that the gestational sac is seen at about 4.5 to 5 weeks on transvaginal sonography and about a week later on transabdominal sonography. Here are the findings that we define as indicative of an intrauterine pregnancy for an emergency physician sonographer, and that is the presence of a gestational sac with a yolk sac inside. And as we see in the picture to the right, the yolk sac has a circular type appearance that we call the positive Cheerio sign. Thus, just remember, gestational sac plus yolk sac is indicative of intrauterine pregnancy. However, bonus points are given if you see a fetal pole with a heartbeat for confirmation of intrauterine pregnancy. Here's a video clip showing a definitive intrauterine pregnancy. What we see here is a larger gestational sac, and as we look inside the gestational sac, we see the positive yolk sac or Cheerio sign. Notice the circular yolk sac is seen towards the inferior aspect of this gestational sac. So this would be diagnostic of an intrauterine pregnancy, effectively ruling out an ectopic pregnancy in the vast majority of patients. Remember that the yolk sac is seen at about 5 to 5.5 weeks on transvaginal sonography and about a week later on transabdominal sonography. Here we see a pregnancy that is a bit further advanced. Note we have a larger gestational sac, that darker or hypoechoic area within the fundal region of the uterus. And as we look inside the gestational sac, we see the positive yolk sac or the Cheerio. And looking just to the left of the yolk sac, we see a tiny little fetal pole there. Interestingly enough, as we zoomed up on that fetal pole, we could make out the flicker of a heartbeat. So a definitive intrauterine pregnancy. Recall that the fetal pole is seen at about 5.5 to 6 weeks on transvaginal sonography and about a week later on transabdominal sonography. Here's a transvaginal short axis view of a 7-week intrauterine pregnancy. We see the gestational sac here. Notice that the gestational sac is located in the center of the uterus, as seen here in short axis, and there's a good amount of myometrial mantle surrounding the gestational sac, signifying a fundal location. We see the positive Cheerio sign or yolk sac to the upper right aspect of the gestational sac, and right below we see the fetal pole stretched out. Notice the positive cardiac activity as we scan back and forth through the fetal pole. Here's another intrauterine pregnancy at about 7 weeks, again in a transvaginal short axis view. We note the good amount of uterus surrounding the gestational sac, signifying the fundal location. We see here the yolk sac or Cheerio sign and the fetal pole stretched out below the yolk sac. Notice the positive cardiac activity within the fetal pole. Now we see another very important finding here on this ultrasound, which is the amniotic membrane billowing out from around the fetal pole. Eventually the amniotic membrane will plaster down on the margins of the gestational sac to form the amniotic cavity in which further growth of the fetus will occur. Here's an interesting video clip showing a twin pregnancy. What we see here are 2 gestational sacs signifying dichorionic twins, and within each of the gestational sacs we can see little fetal poles with the flicker of heartbeats. Recall that fetal heart activity is seen at about 6 weeks on transvaginal sonography and about 7 weeks on transabdominal sonography. Here's an early second trimester pregnancy. What we see here is the next Oscar de la Hoya. Note the mean right hook on the baby here. So the important finding here is that this is an intrauterine pregnancy, as we can define a good mantle of uterus surrounding the pregnancy. And that's very important, as there are some ectopics that can grow to an advanced age, but they're discerned by a lack of uterus around the pregnancy. Here's another second trimester baby, and as I work in northern Manhattan, I refer to this baby as the merengue baby. And note the baby moving around fluidly within the amniotic sac. A sure sign that this kid will grow up to be a slick dancer. So in conclusion, I'm glad I could share with you the Soundbites module going over emergency OBGYN ultrasound, part 1 of intrauterine pregnancy. Emergency OBGYN ultrasound is definitely one of the most helpful sonographic applications in a busy emergency medicine practice, and hopefully by going through the module you now have an understanding of the ultrasound findings diagnostic of a normal pregnancy. I hope
they say retention about 10%. Right? Even if we kept 10% of that, that's good. So what it means is watch it a few times. It is going to be posted. And what I'll do in this case, I'm going to post the videos just on their own. So you don't have to watch the whole thing of us talking now, so that you guys get the hang of actually seeing intrauterine. Yes, I'll put that on the group, so at least you guys will have it. Now, unfortunately, we have to make it through 7 more minutes of him, right? So he has his moments, but overall he's like a kind of thing. But the knowledge is there. That's the important thing, you know. And the sad part is, unfortunately, because we don't have obstetrics here, there's no way for me to do it myself and teach you guys. So that's why I had to resort to these videos. Okay. So the next one we're going to see is just a bit more involved, but it's very interesting. All right. Like I say, don't worry about the presenter. Look at the presentation. Okay.
In this module entitled Emergency OBGYN Ultrasound Part 2 of Intrauterine Pregnancy, we're going to focus on the further assessment of normal pregnancy. We'll look at two further things that are important to assess in your pregnancies. First of all, learning how to date the gestational age of the pregnancy, as well as learning how to determine the fetal heart rate. And then we'll wrap up the module by examining further findings in abnormal pregnancies and learning how to differentiate these findings from a normal intrauterine pregnancy. The first concept that we'll focus on is dating fetal gestational age. Now, in the first trimester, we're going to use an assessment of the crown rump length. Interestingly, dating in the first trimester is actually probably the most accurate during all phases of pregnancy, as there's a difference in the growth curve as the fetus develops. In the second trimester, we'll measure the skull biparietal diameter, and in the third trimester, the dating is composed of a biophysical profile focusing on the femur length as well as other biophysical measurements. This is an image of a first trimester pregnancy, and we're going to evaluate the gestational age by measuring the crown rump length. Here we see the fetal pole stretched across the gestational sac, and we see the crown located over towards the right and the rump towards the left. If we put the calipers down from crown across to the rump, we get a measurement of 1.46 centimeters. Now, by selecting crown rump length in the software package on the ultrasound machine, we'll get an assessment of gestational age, which we can see here towards the bottom left, 7 weeks and 6 days. As first trimester dating is considered one of the most accurate during the entire pregnancy, it's nice to print this image out and give to your patient to take for their follow-up visit with their OBGYN. In the second trimester, dating of gestational age focuses on skull circumference or measurement of the biparietal diameter. We want to measure the skull at about the level of the thalamus in an axial orientation with the face down. As we can see here, we're placing the calipers from the outer skull table proximally to the inner skull table distally, and we have a measurement of 3.26 centimeters correlating to a 16-week, 1-day gestational age. In addition to measuring the gestational age of the fetus, another very important concept is to get a measurement of the fetal heart rate. Now, normal fetal heart rates will range from 120 to 160 beats per minute, but lower rates down to 90 beats per minute can be seen in early pregnancy in the early parts of the first trimester. M mode is the best method for determining fetal heart rate. Power Doppler, in contrast, gives more ultrasonic energy to the developing heart. Thus, M mode is the preferred way of measuring the fetal heart rate at this time. Here we're going to use M mode to determine the fetal heart rate. Notice we have the fetus zoomed up towards the top of the image, and we're placing the M mode caliper directly over the fetal heart. Towards the bottom, we see the M mode motion strip, and notice the little waves showing the motion of the fetal heart. In this particular ultrasound machine, we need to measure between each peak, and we can see here that we get a heart rate determination towards the bottom, 158 beats per minute. This is something we can print out and place on the chart to show that at the time we saw the baby, there was an actual heartbeat. While fortunately most pregnancies have a successful outcome, unfortunately there are going to be some abnormal pregnancies that we'll see in the emergency department consistent with fetal demise. Some of the measurements we'll use to determine abnormal pregnancy with fetal demise is a very large gestational sac greater than 10 millimeters if no yolk sac is seen. Once the gestational sac is greater than 18 millimeters, we should see a fetal pole, or else this is an abnormal pregnancy. And many times the gestational sac in an abnormal pregnancy will have an irregular shape with a scallop-type appearance to it. Here's video from an abnormal pregnancy. The first thing we notice is a very large gestational sac without a yolk sac or discernible fetal pole with heartbeat. We also see the presence of subchorionic hemorrhage to the superior aspect of the gestational sac. That's that area of dark or anechoic fluid surrounding the gestational sac, and this is seen commonly with abnormal pregnancies or spontaneous miscarriage. Here we'll put the calipers down to measure the diameter of the gestational sac. Note that it's very large at 2.8 centimeters by 1.6 centimeters, much larger than the 1 centimeter mark that we said defined an abnormal pregnancy if there was no yolk sac, or 18 millimeters if no fetal pole was seen. Other indicators of an abnormal pregnancy with fetal demise is a gestation greater than 7 weeks, which is abnormal if no fetal heartbeat is seen. And if the fetal pole is greater than 5 millimeters in dimension, this is abnormal if no fetal heartbeat is seen. This was an unfortunate case in which we see a large fetal pole greater than 5 millimeters without a heartbeat. This is indicative of embryonic demise, and we also see a large circular amnion within the gestational sac. Now, while I do think it's important we're able to pick up the findings of an abnormal pregnancy, I'm always going to get a confirmatory ultrasound and/or OBGYN consultation before giving the patient the news that there is a fetal demise. I'd like to conclude this module with another form of abnormal pregnancy, which is a molar pregnancy, which is a form of gestational trophoblastic disease. Now, gestational trophoblastic disease ranges from a spectrum from a benign hydatidiform mole to invasive choriocarcinoma, a form of metastatic disease. The majority of these are derived from paternal chromosomes. There's no maternal chromosomes in the embryo. The ultrasound appearance will be a cyst-like bunch of grapes with a snowstorm-type appearance, and classically the serum beta-HCG will be very elevated. Here's video from a patient who presented with a molar pregnancy. Her presenting symptoms were uncontrolled hypertension during the pregnancy, as well as vaginal bleeding and pain. And what we see here is the presence of a molar pregnancy within the fundal region of the uterus. Notice it has a cyst-like type appearance, very different from the normal appearance of an intrauterine pregnancy. As we scan back and forth, it almost looks like a bunch of grapes within the fundus of the uterus. So a diagnosis of a molar pregnancy, and my next move was to get an OBGYN consultation.
Well, that just gives you some basics on measurements and abnormalities. But one thing that you mentioned over there that's very important, if you suspect intrauterine death, don't disclose the news to the patient. Get a confirmation, either from a senior doctor, like if we're here in the emergency department, and even then too, I would still ask radiology. If I'm not sure, or radiology is not sure, we get OB/GYN to have a look and see. Because the worst thing you can do is tell somebody the child is gone, and in the meantime, that heart is just hiding at a position that you couldn't see it, mainly because of experience, a radiologist and an OB/GYN and an obstetrician have seen much more than what we would see. So we suspect, but we never confirm. It's very important, especially when we're dealing with cases of trauma. Where it's in any case you're dealing with the trauma, and now you have to worry about this. And moms are always worried about their babies. They won't worry about themselves. The head could be hanging off that way. My baby, all right, But you've got to be 100% sure, really. I remember a case about 2 or 3 years ago. We had this young lady, might have been about 28 weeks, first pregnancy. And for all intents and purposes, that baby had died, And she only kept on asking, is the baby okay? Is the baby okay? Is the baby okay? She asked and asked and asked. All my interns, I remember standing over there, they're looking at me, like, tell her. Like, no, refused, didn't. We left it. When she went to ICU and she was there, radiology went up. Radiology did everything, and then radiology told her, your baby has disease. You get what I'm saying? If we had told her in that situation, while she's busy dealing with her own trauma, she had a fractured femur, she had a C-spine injury, she had a lot of things that were going on at the same time. It's not the time or the place, what I mean? The baby is gone, even in that case, but just don't do it. The other thing I want to say is these molar pregnancies, everybody describes it as a bunch of grapes. Nobody's going to remember a bunch of grapes. It looks like SpongeBob. Right? Imagine a mom is pregnant with SpongeBob. That's what it looks like. You will never forget what a molar pregnancy looks like. Okay. So that's what we're going to cover today. Now, like I say, I'll post just these videos as well. Keep these on your phone, keep these on your laptop, keep them wherever, and revise them over and over and over again. Are they exhaustive? No, there's a lot more that you can learn, but this is a good starting point at least, and then you can practice on patients and learn more from the textbooks as well. Right? Now, I hope you guys will watch it a few times, because then what it means is that when we get to ectopic pregnancies next week, unfortunately, we got to get through 15 minutes more of him, all right? But he's not so bad, but I find him a bit boring. But they've got wonderful lectures. I've learned a lot from them actually, but I do fall asleep. So generally what I do is when I'm sitting, if I'm on my exercise bike, I put it on there because I can't fall off to sleep on the exercise. It's fine, but I tend to slow down. All right. But just in terms of what we had today, does anybody have any questions or anything that they want to know? This is not in-depth obstetric ultrasound, because that's not what our job is in the emergency department. Our job is to see what is going on. If anybody on Zoom also has a question, by all means, you can either talk or send us a chat. I'm not sure. Have a look and see. Okay. I think through the chat would probably be easier. But if there's no questions, that's grand. Not a problem, because we do have to get to work. But what we'll do then next week is that we'll cover now ectopic pregnancies and a little bit more of abnormal pregnancies as well. As I always say, our job in the emergency department is to find, stabilize, and pass on. We just have to suspect if it's an ectopic. Then we do our tests, and if we get a confirmation, great. But it's not for us to sort it out. There are certain things that need to be done in the emergency department for a patient who's got an ectopic pregnancy, and we'll get to that next week. I don't want to get to that now. But the important thing is let's learn what a normal pregnancy looks like on ultrasound. Let's have a look at how we can measure kids, things like that. And then next week we'll cover all of that. All right. So luckily not too long today. And we're going to end it there. If you'll have questions after, you're welcome to message me or ask me. Okay. All right. And thanks everybody on Zoom. Bye.